Good afternoon. My name is Ashley Hawes, and I'm the Director for Consumer Information at Benjamin Rose Institute on Aging. This session is being offered as part of the Administration for Community Living Alzheimer's Disease Program Initiative Project, expansion of dementia-capable communities within urban and rural settings in Ohio, using evidence-based and informed programming. Thank you for joining us today for behavioral interventions when caring for someone with dementia. We are very fortunate to be working with our partners at Memory Lane Care Services and the Ohio Council for Cognitive Health to offer this webinar for the third and final time as part of this project. Today's webinar will be recorded. During the webinar, you may submit a question at any time using the Q&A button at the bottom of your screen. We have staff monitoring the questions in the chat to convey your questions to our presenters and to answer any technical questions that you may have. You can turn on captions by selecting Live Transcript, the button with two C's at the bottom of your screen. We are conducting an evaluation of our dementia education sessions as part of this project. You should have received an email with a link to the pre-session evaluation questionnaire, which also contains further information about the evaluation. If you did not have a chance to complete the pre-session questionnaire, we ask that you please complete this now using the link provided in the chat. By doing so, you are helping others in your community. Your responses and feedback will be used to show the impact of programs like these and to improve the tools and resources provided to individuals living with dementia and the people who support them. I now have the pleasure of introducing our speakers for today's session. We have Lindy Wierstek. I'm sorry, Lindy. She is a social worker from Memory Lane Care Services. She is a care consultant who works with caregivers and individuals with dementia to help them through decision-making, struggles with day-to-day challenges, and planning for the future. In her current role, she is primarily responsible for supporting successful execution of the ACL Northwest Ohio Dementia-Capable Grant and offering the evidence-based BRI Care Consultation program. We also have Marty Williman, who is the Program Director for Ohio Council for Cognitive Health. She holds a bachelor degree of science and nursing from Madonna University. For the past 20 years, Marty has provided education and support to individuals living with a diagnosis of dementia, care partners and professional caregivers through education programs, care consultation, helpline, early stage programs, and advocacy. Please join me in welcoming Lindy and Marty.
Thanks, Ashley. It's great to be with you today and Lindy I'm sure would agree. She's going to kick things off with the next couple slides.
Thanks, Ashley. Thanks, Marty. So hi, everyone. My name's Lindy, and Marty and I are going to be delivering today's program, and we're just, again, so excited to be here. Just to echo everything that Marty had said, we have a really great presentation on behavioral interventions when caring for someone with dementia. So it's going to be a really wonderful presentation. This is a wonderful program for professionals, family caregivers, and really anyone interested in learning more about caring for someone with dementia or even communicating with someone with dementia. There's a lot of great practical tips that we're going to talk about throughout the course of the day. So with that being said, just to acknowledge the Administration for Community Living for the grants that support this work as well as the delivery of this program. And in addition to that, I just want to acknowledge the State of Minnesota Act on Alzheimer's. A couple of the resources at the end of the presentation are through the State of Minnesota. They have a wonderful website full of resources. And they also generously shared some of their training materials that helped us create this behavioral interventions program. So just to acknowledge them as well. And we'll move to the next slide. So I'm just going to read out loud today's learning objectives, and we'll go over all of these wonderful key aspects of the training during today. So we're going to identify different causes and different types of dementia. We're going to look at how we can understand the importance of timely detection of dementia and effective tools to identify dementia. We're going to look at what are common behaviors among people who are living with dementia. as well as learning methods for analyzing these common behaviors, as well as determining those causes of challenging behaviors. We're even going to go as far as applying interventions to reduce behavioral symptoms and implementing systematic non-pharmacological approaches to manage these behavioral symptoms. And then again, at the end of today, we're going to look at some really great, some of them are online, some of them are some books. We're going to look at some resources to help professional caregivers and family caregivers as well. And we'll move to the next slide. So during today, we're going to look at a couple different case presentations or case studies. And this is the first one. In this one, I'm just going to kind of read out loud and get your wheels turning. I'm hoping that this kind of sets the tone of why we're talking about behavioral interventions. During the course of today's presentation, we're going to be looking at tools of how we can analyze cases such as this one, and how we can use those tools to really improve the quality of life for the individual living with dementia and the family as well. So I'm going to read this case study again to help set the stage. So Jane Smith is 76 years old. She lives in the home of her daughter and her daughter's husband. The daughter and husband have 3 adult children living out of the house. The daughter has come to you with concerns that Jane is quick to take offense at almost any suggestion from the daughter. Jane resists taking showers, claiming that she doesn't need to take a shower that day. There have been occasions when Jane has gone almost 2 weeks without bathing. Furthermore, when making suggestions to Jane, the mother often responds with belittling things about the daughter. You are fat, you are stupid, you never did have good sense. The daughter said she would like to keep her mother at home, but doesn't know how much longer she can go on in her caregiving role. And a little bit more information is that the daughter says that she's been told that Jane has dementia. She doesn't know if it's Alzheimer's disease or another cause of dementia. And she knows that her mother takes a pill and a patch for Alzheimer's, as well as something for her blood pressure and sleep. So again, just to kind of set the tone of why we're talking about this, I'm sure we've all heard a case such as this that has been very concerning to the family. And how do we go about addressing it? And again, that's why we're talking about this today. And I believe I'm going to kick it over to Marty to talk a little bit more about dementia.
Thanks, Lindy. I agree. That's a pretty common scenario in my history of work and my experiences in working with families with dementia. I come from a background of home health care, where bathing was certainly an issue in a lot of the homes that we went into. So there are actually other case studies within the program. We just picked out a couple of them. The next case study that we're going to present actually will focus on an individual with Down syndrome and dementia. So stay tuned for that. But in the meantime, we just want to give you a basic overview of dementia and review kind of quickly with you the signs and symptoms of dementia. And there are many. These are all going to vary from individual to individual. Every person with dementia is unique, as you know. So some individuals will experience more memory loss than others. Some might have more behaviors than others, but just a quick review of those symptoms. And remembering that when we identify memory loss as a symptom, we're always talking about short-term memory loss. And sometimes our families don't understand this. They can't understand why dad can remember things from the 1950s and he can't remember what he did, today. It's the short-term memory loss that's affected. Also confusion, losing track of the day, the week, even in the home setting where their home is. Same way with disorientation to time and place. Getting lost in familiar locations. The person that's gone to that same barbershop for 20 years now has trouble finding it, gets lost on their way to it or on their way home. Changes in speech and language. And that's what this behavioral interventions program is all about, is when people's ability to communicate changes due to dementia, they will rely on showing you what they need. And that a lot of times we will term as a behavior. If I can't tell you that my right hip is killing me, and I need some Tylenol arthritis, I will show you by refusing to get up. If you assist me to get up, I might push you away because that pain is so severe in me. So I will show you what I need if I can't communicate it. Trouble with time and sequencing of events. Trouble with judgment and problem solving. Decision making. Changes in sleep and appetite. And again, changes in behavior, personality, mood. Individuals with dementia will lose the ability to care for themselves will decline, their hygiene will decline without the proper assistance. Again, those familiar tasks that seem so easy to us that do not live with dementia are actually very complex. We do an activity with our Dementia Friends session where we ask people to list some of the steps to brushing your teeth. You might be surprised to know there are over 40 steps for just that one task. Those tasks can become frustrating for a person, and they might let you know it's too complex by, again, pushing you away, refusing to do the task. So we need to know that about the individual, and we need to know when to step in and uncap the toothpaste. So that's not one of the steps that needs to be done. To turn on the water for the person so they don't have to decide which lever to engage in the sink. Those fluctuating abilities, and this also can be hard for caregivers, because if I'm living with dementia, I might be able to get dressed, tie my shoes one day, but then the next day it might be impossible for me to do it. The abilities really fluctuate in individuals with dementia. And then the diminished insight can really lead to some problems with judgment and decision making, and even getting a diagnosis. We hear from a lot of family members who say, mom doesn't think anything's wrong. When I take her to the doctor, she denies everything. She says she's fine. Well, that might be a defense mechanism on her part, but a lot of that also is that diminished insight into one's own condition, that difficulty with abstract thinking. So a lot of signs and symptoms there, but just know that, again, when a person loses the ability to communicate, this will turn into perhaps some of these behaviors that we're going to talk about. So the behavior we want you to think about as just a means of communication. When we talk about what the definition of dementia is, we define it as this decline in cognitive functioning and mental functioning. It's more severe than age-related difficulties. And the last point is crucial. Those changes are at the level where they're interfering with the person's ability to get through their day. It interferes with their ADLs, their IADLs, their independent activities of daily living, and their social relationships. So, forgetting to pick up that loaf of bread when you go to the grocery store is much different than when you get the loaf of bread home, you don't know what to do with it. You don't know what the function is. So we all have, age-related changes as we get older with our memory, but when they get to the level where they're interfering with those daily activities, then we say it's time to get checked out. I like to stress too that sometimes people will have some of these signs and symptoms of dementia, and they can be due to non-dementia causes. If I'm not sleeping well, if I'm depressed, if my meds are interacting with each other, that's causing me to be forgetful or confused, if I've got an infection going on or dealing with chronic pain, there are a lot of reasons people can show some of these signs and symptoms that are not due to dementia. So it's crucial that when we see signs and symptoms in someone that we know or are concerned about, that we assist them in getting to a healthcare provider that can really do a diagnostic workup and to rule out other causes of these signs and symptoms of dementia. Some of those causes might be mixed dementia. Lewy body dementia. As you can see in this slide, there are many different kinds of dementia. Alzheimer's is the most common type. We estimate that it makes up about 60 to 80% of all dementia, but that's just one kind of dementia under this big umbrella of dementia. We hear a lot in the news today about frontal temporal lobe degeneration because of Bruce Willis's announcement of his disease, his family's announcement. We hear about Lewy body dementia, and that will be associated with some Parkinson's symptoms, shuffling gait, tremors, those types of things. Visual and auditory hallucinations can sometimes be common in individuals with Lewy body dementia. With vascular dementia, the individual may have had a history of heart disease, heart problems, where they've had interrupted blood flow from the heart to the brain, and it's caused that kind of dementia. We're not going to go into the specific definitions of all of these, but just know that Alzheimer's is just one kind of dementia. There are many other ones. But again, Alzheimer's is the most common type. So timely detection is important, and Lindy's going to go over the next couple slides here in regards to this.
Thank you, Marty. Yes, so with Marty's, describing different causes of dementia, it's important to talk about timely detection and getting a diagnosis or seeking a diagnosis, or finding out, is there something else going on, is truly really important. So we know there isn't necessarily a cause or a cure of Alzheimer's disease or other forms of dementia. But there is reasons why, again, timely detection is important. And some of them, those are listed on the screen. They're really most important to get a timely detection, though, because underlying cognitive impairment is an obvious risk for an individual's ability to effectively manage other health conditions and comorbid conditions. So we know how important that is. It's not just about treating dementia and identifying dementia. It's about removing a hidden barrier to a good compliance with other conditions such as diabetes. And I'm actually going to share with you a common scenario that I think will help, put everything into perspective. So let's say an 80-year-old person comes in for a routine health visit. They have a medical history of diabetes. Their A1C is significantly elevated, suggesting that her diabetes is not well managed. When asked if they are checking their blood sugar and taking their insulin regularly, the patient says, well, yes, I am. And they offer what most individuals do in this situation, a socially acceptable response. So the provider then increases their insulin and adds more medication to help address the problem. But then, of course, the elephant in the room is that there's unrecognized dementia, and the individual can't remember to do these things on a daily basis, nor can she do the math required to draw the right amount of insulin. So instead of removing this barrier and getting support for medication administration or medication reminders or assistance, we're really just adding more complication and risk by increasing, or changing medications. So this, again, is a very common scenario. And that's one of the reasons why we really want to seek out a diagnosis or timely detection of dementia. In addition to that, the earlier detection allows for individuals to be a part of their own care plan, and to talk with family members and friends or professionals about what they want for their life, and in that plan, for their care plan as well. And just, a couple of reasons why it's really important to get a timely detection. So we'll move on to the next slide. So there are a lot of different tools out there, cognitive assessment tools, as Marty mentioned before. It's really important that you seek out the official diagnosis from a healthcare provider, primary care physician, to get an official diagnosis. But there are tools available that sometimes are used by physicians, and some of them are just available right online, and you can actually do with a pencil and a piece of paper. So there are literally hundreds of screening tools available. They vary by length, and their ability to accurately and timely detect, of course, dementia. So just to highlight a couple of these, and again, you'll get the presentation for today, so you can actually go back and click on the links to these assessment tools and kind of learn more about them if you're not familiar. But for example, the SAGE exam is one of those exams where you can print it out and do it just right there with a pencil and a piece of paper. So that's the self-administered geocognitive exam. So again, this is something that an older adult might be able to do and administer themselves to kind of alert if there's any red flags, if they have concerns, and then again, they would take these results to their doctor. Another interesting assessment tool that was designed and created is the NTG screening tool, which is early detection screen for dementia. This was actually created specifically for individuals with intellectual and developmental disabilities that can be used to screen those individuals who might be showing early signs of mild cognitive impairment or dementia. So not to get into too much detail, I'm sure you're familiar with the mini-cog or the MMSE, but just to note that there are cognitive assessments out there that are available just on the internet, and again, to contact your physician to get an official diagnosis. So we'll go to the next slide. And yep, sounds perfect. Thanks, Marty. So with that being said, we are going to talk a lot about today non-pharmacological interventions, and in looking at the environment and the person, and that's kind of the care and treatment approach that we're going to talk about today during the presentation. We also are going to look into the importance of connecting individuals to local resources, or if you're a caregiver yourself, to look into what local resources are available, and to make sure at any stage, at any time with any disease, to refer these individuals to local resources. As much as we would wish that all physicians would be familiar with all the local services and supports that exist in the community, sometimes they're just not. So for professionals working in the community, we want to make sure we're working with families to provide them with information about services and supports that are available. So we'll go to the next slide. Okay, so we know that mood and behavioral symptoms can be very common. So up to 80% of nursing home residents actually have dementia, and we know how uncomfortable and challenging these behaviors can be for professionals, for family caregivers. And what we are going to talk about is how great it would be to reduce some of these behavioral symptoms. And we're going to define here in a minute, what are those behaviors that we keep talking about, all these behavioral symptoms, but what are they? But we're going to talk about how effective it will be to just reduce some of these behavioral symptoms, to reduce early nursing home placement, and to give support to families and tools that they can use to reduce these mood and behavioral symptoms. And we know how common and discouraging and difficult they can be for our families. So I'm going to give it back to Marty, and she's going to talk about some of these behaviors that we keep mentioning.
Yeah, I find it, I still find it shocking that almost all people with dementia experience some kind of, change in mood, personality, behavior. So this is such an important webinar that we're presenting here today. Behaviors obviously will have negative outcomes. They decrease the quality of life. This is all pretty self-explanatory, but you might not know that they actually do. This is documented. Behaviors do increase hospital length of stay. They increase health system-wide and community-wide costs, certainly increase caregiver distress and burnout. They can be linked to premature nursing home placement, and they also lead to increased mortality. So if nothing else, these really identify the reasons why we need to look at behaviors, to identify them, to look at the root cause, interventions to prevent them from happening, or at least dealing with them in the best way that we can possible. So what are some of those common dementia-related behaviors? These are just, some of the more common ones. We certainly haven't listed all of these here, but these are the ones that we're going to talk to and refer to during the rest of the program. So some considerations, and you may not have thought of this one yet, but when we see a behavior, we need to ask ourselves, is this behavior really a problem? If it's a problem, who's it a problem for? Is it a problem for the individual that lives with dementia, or is it a problem for the care partner? Are there things that we can do to diminish that, or to help that caregiver really look at that as that behavior as, is this really a problem, or do I just need to maybe, look at a different way of dealing with it, or maybe not get too caught up in it? So, for example, there may be an individual who just loves to move the chairs around in the dining room. And this may be problematic in some ways, but yet it might not be if we really look at that situation. If it's problematic for the caregiver, whether they're professionals, paid caregivers, or whether they're family caregivers, then we need to look at ways of maybe modifying the environment, using distractions for that individual, or maybe that individual just wants to keep busy by moving those chairs around. So we can really work with the caregivers to, to identify that. Is it hurting anyone? Is it bothering or causing problems for anyone? And realize that some behaviors are common. Sometimes care partners have unrealistic expectations. We need to advise and help those care partners just to try to take a deep breath. I think it's offering respite services, getting some resources in that home to give that caregiver a break. So when we look at the causes of challenging behavior, we want to look at the physical health. Is this behavior related to pain that individual is experiencing? Is it, Lindy, I think I'm taking over here. Sorry, I'm going to go back.
No, you're fine. No,
I just looked at my notes. Sorry.
You're good. No, go ahead. You can go ahead and move forward. Well, I'll just piggyback off of everything you were going to say, Marty. So we'll look at other causes of challenging behaviors. And the first thing we want to look at is physical health and the medical aspect. So these are things we want to rule out before we look at interventions, before we look at pharmacological interventions. So we are looking at, is the person in pain? Marty gave an example earlier of, is it arthritis? Is the person not being given a regular or small dose of pain medication to help with just aging pains? It's interesting. I was talking with a family caregiver recently, and they had mentioned that the person they were caring for was really yelling out and was not sleeping very well. And we started to talk, and it's one of the things she mentioned is, well, they do have pretty severe arthritis in their back, in their shoulder, and that was part of that communication. Was her yelling out and saying, I'm in some serious pain. So we were able to identify that this challenging behavior, the root cause was pain. In addition to that, we want to rule out if something has changed quickly. Is it a urinary tract infection? Are they just sick? And again, cannot communicate, hey, I'm just not feeling well. I think, I guess for me personally, I have the luxury to be able to identify, I'm sick, I'm not feeling well, I can take some cold medicine or whatever the case might be. But with dementia, we know that sometimes communication can become more difficult. Being able to express what's going on can be more difficult. So the next thing we'll talk about is the environment. And in a little bit here, I'm going to actually go into a little bit more in depth of how the environment can actually cause some of these challenges. Sometimes, just to name a few, it's the person's in an unfamiliar surroundings, a place they've never been before. It's out of their routine, and they're, feeling maybe a little uncomfortable. We'll talk more about, are they being overstimulated or understimulated? Just to briefly touch on that, is there just way too much going on? You know, and I'll give other examples of this later, or is there just nothing for them to do? So over and under stimulation could also cause different challenges. So, and then with other causes of challenging behaviors, we have communication. That can be, and these kind of specifically look at the individual who does not have dementia, so the care partner, the caregiver, professional, how are they communicating with this person? Are they giving too much detail in their communication? Is it causing them to, the person with dementia, to be frustrated? Or do we have unrealistic expectations for the person? Our expectations are too much. We need to consider the person's, that they have a disease, and go from there. Again, talking about unmet needs. Are they just bored? They don't have enough to do? Are they given tasks that are too difficult, or they're perceiving maybe it's too childlike? So looking at all of these different things, and then is it their emotional health? Is there other mental health concerns going on, or are they having, maybe they're experiencing grief or loss of their own, and something that they can't exactly articulate or communicate? So again, these are all other causes of challenging behaviors, and we'll move to the next slide. So more on physical unmet needs as causes of behaviors. So I always just think of myself, how I would feel if I could not, communicate that I'm just tired. I'm tired out, or maybe I'm thirsty, or I'm hungry, or maybe I need to use the restroom. So that's why things like having a restroom routine, giving bathroom reminders are really important, because maybe this person is experiencing anxiety or yelling out or frustration, or even other behaviors that Marty had mentioned, because they simply have to use the restroom and they can't communicate that. Again, we keep talking about discomfort. Pain is a big one. Could it be constipation? Is it something simple as their skin rubbing against each other? It's just something uncomfortable. So looking at the person and seeing what you could do to increase their comfortability and how you can help them. Of course, there are brain changes to take into consideration, such as hallucinations and delusions, that could be a cause for these things. This is something you can look at and examine, and also talk with the healthcare provider about. Another important piece is medication interactions, and the way that medications can interact with one another and could cause different side effects. It's really important to either talk with a pharmacist or healthcare provider, bring a whole list of medications to the visit, and see if maybe one of these medications is causing one of these behaviors, and maybe that can be addressed and reduce that behavior. So all things that we can look at. Another piece could be looking at vision, hearing. How can that affect the way that they're communicating? I work in an adult day center, and I'm really familiar with one of the participants who comes to our center. And I had walked up to her and I started talking to her. I was like, "Hey, how was your weekend? How are you doing?" And she's very well able to communicate. And she kind of was looking at me like, "I have no idea what you're talking about. I thought I had made a grave mistake. Maybe my questions were too complicated. Maybe I needed to simplify." And as I was decided, I was like, okay, maybe I'll revisit this individual later and say hello. I realized I was talking to the wrong side of her hearing aid. She has a hearing aid in one ear and not the other. So I moved around to the other side and I started talking to the ear that had her hearing aid in, and we were able to have a wonderful conversation together. But small things like hearing, that was the whole reason we were unable to communicate, is she wasn't hearing me. And for me to be able to look at that and address that changed the whole conversation, and for us to be in communion with one another and have a good conversation. So just things to consider. We'll move to the next slide. So this is just more on environmental causes for behaviors. So this is something that I hope that we can all take into consideration. If you're working with individuals who have dementia, look at the environment that they are in. Is there too much noise, activity, people? Is there too much clutter? A lot of times I talk to caregivers a lot of times on the phone, and sometimes I'm talking to them and the TV will be blaring and the dog will be barking and there's, maybe someone else in the background. So sometimes I have to politely say to them, is there any, can you hear me okay? Or is there any way you could turn on the TV, or I'm having trouble communicating with you? But if you think about someone who's having trouble with reasoning and with judgment and with processing, if they're in a room and they're overstimulated, how overwhelming that can be. Again, on the opposite side of that is they're too little to do, too little to touch, too little to see. I think sometimes if we think of maybe people who are in middle or later stage of dementia, caregivers feeling and thinking, well, they can't comprehend what's on TV, or they can't comprehend, books anymore, then maybe they take those things away. But in reality, can we give them something? Maybe it's something that they can hold. Maybe it's, a fur, stuffed, animal, something that can give them a little stimulation. So can we reassess what would be helpful and meaningful to them? Maybe it's not what it used to be, but could it be listening to the radio? Could it be something that's meaningful to them? We also try to keep things calm, cool, and collected. Sudden movements and startling noises can be upsetting and can cause behaviors. So we always say stay calm, cool, and collected. Even if there's something going on that's not so calm, cool, and collected, like if there's emergency, we still want to stay as calm and cool and collected as we can to just make them, reassured as well. The last piece I'll mention is looking at lighting. You think about things like sundowning and sundowners, and how can we make sure that the lighting is the best it possibly can be for the activity, for the time of day. Try to reduce shadows if that's an issue. So we want to be familiar with lighting as well. And we'll go to the next slide. So, other causes, there's, as you can see, a whole list of what are these causes of behaviors, but these are things we really need to consider and just can help us be more knowledgeable of how to, again, improve the quality of life for people living with dementia. So if individuals are feeling lost, they're feeling insecure, they're feeling forgotten about, maybe if their caregiver or person is not visible, that can of course be upsetting. Again, I touched on earlier, if instructions are unclear or too complicated, then I think I'm frustrated too. If I think about, my own life, we want to make sure that things are not too complicated. And we want to make sure it's at the right level for that person. So really assessing what are their strengths, what are their abilities, and how we can use those strengths to build activities for them. And we're going to talk about activity building and using strength-based perspective later too. So could it be a change in routine? Could it be, they're out of their environment, it's a new change in routine that can be causing challenging behaviors as well. Also, we really are going to take a look, I guess I would say, within. So people who do not understand dementia or are not tolerating these changes or having these unrealistic expectations, then they're going to potentially cause or increase these behaviors because they're not changing the way that they're interacting or communicating with these individuals. And we have to accommodate the person's needs as things ever so frequently change and fluctuate with their abilities. We have to do our research, and we have to understand how we can accommodate them. They're not going to change, we have to. So those are just some tips of how we can reduce, again, some of these behaviors. And Marty is going to jump in and talk about some interventions in a case study as well. So Marty.
Thanks, Lindy. So we've looked at different kinds of behaviors. We've looked at a lot of different possible causes for that behavior. Now we'll move on to look at some of the important interventions. And we're going to go to another case study. This one is with Tom Baker, who's 51 years old. He works part-time at the local grocery store and shares a group home with 4 other males ranging in ages 40 to 50 years old, who also live with Down syndrome like Tom does. Tom's father's 89 years old. He serves as Tom's primary care or source of support, including a guardianship. And Tom's father lives in his own home in the same town. One adult sibling also lives nearby, while the other 2 adult siblings reside in neighboring states. The father comes to you with concerns of Tom's recent weight loss, refusal to talk and participate in usual activities, and tells you that Tom is crying a lot. He also tells you that Tom can't seem to remember how to do simple things around the house anymore. And on one recent occasion, he struck out at the group home manager. He's worried that if this continues much longer, Tom won't be able to remain in the group home that he's always loved. The father states that he is also concerned about his own health and the added care responsibility this will likely place on his other 3 children. Some additional information. The father tells you that a year ago, a doctor told him that Tom most likely has Alzheimer's disease. And this was about the same time that his wife, Tom's mother, was diagnosed with cancer. Sadly, she died 1 month ago. Tom takes daily prescription medication for his thyroid and arthritis, and occasionally takes over-the-counter medication for heartburn and constipation. So with this, we're going to move on to look at how we might apply some of the interventions, look at some of the possible causes for the behaviors that Tom is experiencing. We do the old, the good old who, what, when, where, and why, and I'll go into this a little bit more in the future, but I did want to add that in regards to dementia and IDD, intellectual and developmental disability, and particularly the type of intellectual and developmental disability we know as Down syndrome. Alzheimer's is not inevitable in people who live with Down syndrome. Unfortunately, this is a myth that was put out there many years ago, so I just want to make that straight, that Alzheimer's disease, while it does increase with age, like it does for all of us, the risk for dementia does increase with age. We see a rate of about 30% of Alzheimer's disease in individuals with Down syndrome when they're in their 50s. And in this case, Tom is 50 years old. So we're looking at about a 30% rate of Alzheimer's disease. It did say here that Tom's doctor told him he most likely has Alzheimer's disease. That kind of leads me to think about, okay, did he have an official diagnosis done? Did he have official testing? Or was this just maybe an opinion of the doctor? So that I feel like would need to be looked in a little bit more. The other thing I want to say about dementia, Alzheimer's disease in individuals with Down syndrome is some of the signs and symptoms don't match up to the general population. For example, we talked about how memory loss is one of the early signs of dementia in the general population. For those with Down syndrome and Alzheimer's disease, that's not always the case. Changes in abilities to get through daily activities, loss of enthusiasm for normal activities, a change in mood or personality. These are some of the early signs that we see in individuals who live with Down syndrome and Alzheimer's disease. Also, new onset seizure activity is oftentimes a hallmark sign. If you hadn't seen that in the individual before and all of a sudden we see that onset, we might think about possible Alzheimer's disease. Again, it takes a skilled practitioner to sort this all out. So referring that person to a skilled practitioner and suggesting use of that tool, the NTG screening tool that Lindy mentioned earlier, that's specific for individuals who live with IDD, that's also a good idea. So when we think about defining that behavior, we really want to pinpoint what's going on with this individual. You know, when I work with caregivers, a lot of times the person will say, Joe is just not himself. You know, things have just gotten a lot more difficult. Well, in order to best help that family, we really need to pinpoint what kind of behavior is that family dealing with, or what are they concerned about? Is it attention-seeking behavior? Is it aggression during care? And in this case, Tom had struck out to the group home manager, you know, perhaps pushed or hit that person. So that would be a concern. Is it calling out? Tom is crying a lot. Is it sexual disinhibition? A lot of different times. So we just need to really try to point out what type of situation that we're dealing with, so that we can further clarify and start to work on that. Is the target symptom related to mood? Is this person anxious? Are they feeling down? Again, Tom is crying a lot. That's a change for him. Is it irritability? Is it mood? Is it delusions or hallucinations? Is it more of the psychosis? So again, we're trying to really target that symptom and put it into kind of a classification system. And this is so helpful when we report these symptoms to the healthcare provider. It really helps them zero in on what they're potentially dealing with. We also want to identify those reversible causes. Lindy and I have touched on this before, but this is so crucial that we look for those kind of easy answers. Is it an environmental trigger? Is the person, again, overstimulated, understimulated? Is it due to an untreated medical condition that's going on? Is this person getting sick? Are they coming down with the flu, or are they coming down with a UTI? Has the medication regime changed? Perhaps they've gone to their cardiologist, they've gone to the nephrologist, and they've added a new medication, or they've changed the dose that maybe we're not up to speed on. Polypharmacy, you know, just a lot of different medications that interact with each other. If the person's had a recent hospitalization, we really need to think about delirium. Was there delirium that was caused as a result of that change in environment, that hospitalization? And are we now seeing the effects, which can last for months? Delirium can be quite a long-standing condition that can exacerbate the dementia. Are there unidentified or undiagnosed psychiatric illnesses that this individual is living with? Unrealistic expectations or unmet needs from the caregiver. So in Tom's case, I think about his pain. Is pain causing some of the exacerbation of symptoms? He takes something for arthritis, but is that now effective? Does he need something different? Does he need a higher dose or a more frequent dose? He also lives with constipation and heartburn. Are those medications being administered on a regular basis? Is someone monitoring the bowel habits of Tom and making sure he's not experiencing difficulties with those kind of situations? And then a big one, I think, is the fact that Tom's mom died a month ago. Is he dealing with the grief? And we know that in individuals with IDD, a lot of times the grieving process doesn't match what the general population might experience with their grief. It may be a delayed grief, or a delayed acknowledgement that that person is no longer with us. So lots to think about there. And in addition, some other common root causes might be, you know, that anxiety, that invasion of personal space. And not to point any fingers on caregivers, but did that caregiver get too close to Tom when he wasn't expecting it, or when he wasn't ready for that? This will happen a lot of times with bathing situations. We're ready for that individual to start the bathing process, but is that individual ready? And do they have the right mindset for, okay, I need to, you know, undress, I need to get into the shower, all of those things? Do they feel like they've lost control of a situation, or they don't have the choices that they need? Again, infection could be on this list. Sleep apnea is the person not getting a good night's sleep because of their sleep apnea. And we know that that can accompany individuals who live with Down syndrome, as well as those in the general population. So the unmet needs that Lindy talked about before, the understimulation, safety, environmental stressors, and again, caregiver reaction. It's so important that caregivers get as educated as possible on what we can do to assist that person, and understand that disease process, understand what kind of dementia the individual is dealing with. So thinking like a detective, that who, what, when, where, and why. That is the first step in applying these interventions. Where did the situation occur? Where did Tom strike out at the group home manager? Was it in the kitchen? We know that he's lost weight. Perhaps he was really being encouraged to eat something that didn't look appealing to him. Perhaps he wasn't able to identify what was on the plate. So something as simple as saying, Tom, I've made that peanut butter and jelly sandwich that you like. Here it is. Informing the person, not taking for granted that that person can use the fork, the knife, and the spoon. Maybe we need to introduce more finger food so it's easier for that person to get through their mealtime. Did this situation occur in the bathroom with getting ready to help Tom with the bathing process? Who was present? Who was involved in it? Really looking at these, five W's is really important in helping us know what kind of intervention that we can apply into finding the root cause of the problem. Let's see, go on to the next slide here. So some interventions that are just some basic interventions that are really helpful is to really just validate. Tom's upset. He's kind of lost his temper, so to speak. Let's just validate that Tom is upset. Let's just say that out loud and acknowledge that you want to help him, that we're going to take a break, that we can come back to this later. So we want to validate, join Tom in that experience, let him know that we're with him, not against him. And then distraction, a lot of times, is very helpful. Can we move into a different area of the house? Can we turn off that noisy TV, as Lindy mentioned? Can we put on some soothing music? Can we engage in a card game that we know Tom likes to play? Using distraction, redirection is huge in the intervention process. And I'll say it again, we need to ask ourselves, is this really a problem? And if so, for whom? What's that underlying message that this behavior is trying to communicate, and how can we address that underlying need? So when we think about activity planning, this is another part of the intervention process. When we think about offering activities, we want to make sure that they're person-centered. I know that's a big buzzword in dementia care, but it's so important. We want to make sure we're not offering that person an activity that they have no interest in, and that perhaps is now too complicated. We might need to look at that activity and break it down. I worked with a couple who volunteered at the church and folded the bulletins every Saturday afternoon. And the church then went to a process where they had a trifold in the bulletin. And the person with dementia just got very frustrated, got angry, left, would not participate in that activity. And maybe to us, it didn't seem like that trifold versus a bifold really was that much of a difference, but that extra step really threw that individual off. So let's look at the activity itself. Is it too complicated? And if so, how can we adapt that so it's not as complicated and it's more enjoyable for that individual? So a lot of times it's the slowing down with our communication. It's offering simple choices, helping the individual find his or her own words. So we might have to suggest or offer a guess in what that person is trying to tell us. Minimizing those distractions and decreasing that clutter, that can just be so overwhelming for people. We know that when a person has dementia, their brain changes. There's actual, atrophy of the brain. So I just think that if people have too many distractions or are given too much information in too short of a time, it's just hard for that changing brain to process all of that information. And the gut reaction might be to strike out, to yell, to cry. So let's try to employ these communication tips and these environmental tips. And 9 times out of 10, they can make a huge difference in how that person responds to their environment. Supporting the caregiver can't be said enough. And I said it earlier, I think we can employ all of these things, but also we as healthcare providers need to know how to link that person up with community support, adult day services, support groups, respite services, short-term stays in residential care, organizing a team meeting so that everybody in the family knows that the primary caregiver needs a break, and let's set up a schedule. Let's talk about ways we can support that caregiver. These are all things that we as healthcare providers, support providers can help that family with. The last slide, I'm going to talk about our pharmacological interventions. Lindy talked about how the focus of this program is definitely non-pharmacological interventions. That said, we do want to acknowledge that we can try all this stuff we've talked about. We can implement it, and sometimes it's still not enough. And we might have to look at the use of small dose antipsychotics for as short a period of time as possible. But I also think looking at antidepressants, are some of the symptoms related, or some of the behavior related to symptoms of depression as well as symptoms of dementia. A large percentage of people with dementia also live with depression, as do their caregivers. I'm a big one for advocating, talking to that healthcare provider and having that individual assessed for depression. The addition of an antidepressant can sometimes make a huge difference. You can use them in combination with the dementia medications. And with these, we're talking about things like Aricept, Exelon, Razodine, Memantine. Those are the dementia medications. They're not going to slow down the disease. They're going to help with some of the symptoms of the disease. The antidepressants, though, can also help with mood stabilization, obviously depressive symptoms. No matter what we choose here, we've got to involve the whole healthcare team. I love pharmacists, especially geriatric pharmacists, to understand how these medications interact with each other, what the correct dosing should be. So it's not only the physician, the nurse practitioner, the physician assistant, but also that healthcare provider team should have occupational therapy, perhaps physical therapy, speech therapy, as well as a pharmacy and social worker. So let's look at building a whole comprehensive healthcare team to best support this person with dementia. So I'm going to turn it over to Lindy to talk about some of these behavioral intervention tools that are available. She's going to take you through a couple of them. There are a lot of them out there. We've put in just a few of the more common ones into this next part of the presentation.
Awesome. Thank you, Marty. So with that being said, there are, dozens of intervention tools that have repeatedly been found effective for, reducing, those behaviors that we've talked about. And I'm going to highlight just a couple of them, and some of them might work better for you or your personal style, or some of them might work better for the individual that you're working with. So we'll start with the dice. So you can go ahead and show them the dice. So again, this is just one tool that can be used. So it's just a simple way to break down all the steps already that Marty really kind of already walked you through, but this is just one place that everything can be put into a tool. So you're going to describe and define the behavior, look at what is the target symptom. Then you're going to investigate. We talked about the reversible causes, such as the UTIs, the pain. So you're going to look at, are there any reversible causes? One thing that we want to look at is everyone safe? Is the person in danger, or are they at risk for harming someone else? We want to look at that. We want to be a detective and do our investigative work for these couple things. We're going to create a treatment plan. So if we're looking at non-pharmacological interventions, is there something that we can do to, again, join and validate and redirect the person? Is an activity that we can introduce during a specific time of day that the person is beginning to be agitated or anxious? So we're going to create our treatment plan. We talked about these non-pharmacological interventions, but it might be just a fact that medication might be able to really help this person, and it's worth taking a look at as well for a part of the treatment plan. And then you want to evaluate, did this work? Is the person still expressing, this behavior? Do we need to start these steps over and come up with a new plan to how we can address this? So this is the dice. So we'll move to the next tool. So this tool is the idea strategy, or the idea tool. So in a little bit, I'm going to talk to you all about some resources, but this specific strategy actually comes from Alzheimer's Los Angeles. They have a variety of tip sheets, and this is actually just one of their tip sheets, but we thought it was such a great tool, we wanted to incorporate it into this presentation. So this is the idea strategy. As you can see, is in red, you see the ID. So you want to ID or identify the behavior. Again, what is the behavior that's difficult for you to deal with? Be very specific. Can you see it? Is it bothering other people? Is it just bothering you? So you kind of, again, dive into what is the behavior, when does it happen, when it occurs, all those 5 W's that Marty reviewed. So we'll go to the next slide, and the next piece of the idea strategy is the E in exploring. So explore what might be causing the behavior. Again, we talked about these things now in detail, but we'll just beat you over the head with it. So we want to look at health. We want to look at the environment. We're looking at what's being asked of that person. Is it too difficult? Is it perceived as too childlike? Is there a lack of effective communication between you and the person? So we're going to look at all those things, and we're going to just continue to explore. And we'll go to the next slide. So what we want to do is we'll look at the A in the idea strategy, and we'll adjust what can be done. So we've referenced this before, but you are the one who will need to change. The person cannot. So you will need to try different things. Pay attention to the person's feeling, practice being calm, cool, and collected, gentle, reassuring, and keep things simple. Maybe assess and then try again later, as Marty referenced before. And then we'll go to the next one, which is one more piece of the idea strategy, which is just accepting the behavior. I know Marty referenced someone moving tables around, or moving the chairs around the table, or things of that nature. I've heard, that someone was caring for someone who they were unrolling the toilet paper. And that was an activity that they thought was a fun activity, and the caregiver described that as a behavior. But in reality, we could just accept those behaviors if it's not hurting anyone, if anyone's safe. Sometimes you can just accept them rather than try to change them. And that is the last A for the idea strategy. So this next tool you might be familiar with. This is a tool called the EVC tool that was created by Linda Terry at the University of Washington. So this is another tool that really breaks down how to address these things. So it actually has you start with, on the left side, what is the behavior? So what was the person with dementia doing? Who was present? Where was it happening? When was it happening? And then you look at the activator. What just happened before the behavior? Then you're going to look at the consequence. What just happened after the behavior? And then on the right side, we'll look at how you're going to change your approach, how you're going to change the environment. What do you want the person with dementia to do? And what will you do when this happens? And what will you do if the behavior that you would like to happen does not happen? So this is another tool that we can use to try to break down what exactly is going on. And again, to improve the quality of life for the person living with dementia and the caregiver. And we can move to the next slide. So this is another case study that I'll read. And then I think I'm going to take you all back to the dice to just kind of look at that again. But I'll read this case study to you. And this is our final case study. So Helen Rogers is 83 years old. She lives with her daughter who moved from out of state to take care of her mother in her mother's home. So the daughter has come to you with concerns that her mother is constantly moving around the house and rummaging through her belongings. She empties out her closet and drawers, folding and refolding the clothes. She gets up on a step stool to empty out the kitchen cupboards. She washes the shelves and puts the items back. A little bit more information. Helen was diagnosed with an unnamed dementia 7 years ago. The daughter moved home after receiving reports that her mother was leaving the house at nighttime, knocking on neighbors' doors. She was also underweight from poor nutrition. The doctor said that her mother's health was suffering from not managing and taking her medications appropriately. So let's go back up to the dice, and we'll kind of just use this tool. So we kind of look at what the caregiver would describe. The step number one is probably the target symptom, which would be really constantly moving around the house and rummaging through her belongings, emptying out those drawers, refolding the clothes. And that's kind of the quote unquote behavior that is described. So we want to make sure we identify that in detail. And then we want to investigate, are there reversible causes? So is there something medical going on that is creating, some anxiety, or is the individual or Helen, is she bored? Is she in pain, or does she have a UTI, or is there something else going on that could make her more comfortable, that would make her relaxed, or is something else going on? So we look at the big thing, which is everyone safe? So we know that Helen Rogers has dementia. She has been told by a doctor that she was in poor nutrition, and she's getting up on this stool and washing the shelves and putting them back on. So maybe it's up for debate if she's safe or not. Some might say it's not really a safe action for Helen to be getting up on that stool and moving things around. So how can we kind of address this? So we can look at creating a treatment plan. Do we know what time of day Helen starts rummaging around the kitchen? Do we know what happened right before she started doing this behavior? Do we know what happens right after she starts doing this? So we want to, again, and I saw in the chat that some folks are talking about behavior logs. This would be a great place where we could put in play for a treatment plan, a behavior log, what happens right before, what happens after, what time of day, all those things I mentioned. And then maybe also investigating, ensuring that her medications are now correctly being managed. We know when daughter moved in with Helen that the medications weren't really being managed. So is that something we need to look at as well? So putting all that together, we would evaluate the plan that we created. We would implement that plan and then see if maybe that reduces Helen getting up on that stool and in the kitchen and cleaning those shelves if that's something that's unsafe. But maybe it's just a different activity. Maybe she enjoys folding things, and maybe it's helping out with the laundry. Maybe there's some things that we can do to put into place. So that's just one of the tools that can be used and put into play and put into action. So we'll go slide back up to maximizing abilities and activities, and I'm going to give it back to Marty. And Marty, you're on mute. No, you're not.
Thanks. Thanks, Lindy. I think that's a good overview of some of the intervention tools. It can't be overstated, though, that we really need to look at things to help prevent behaviors from occurring in the first place. So making sure that we are focusing on the remaining strengths of that person, that we're offering activities and we're communicating in a way that focuses on their strengths. We're not going to ask them about what they did yesterday if we know their short-term memory is poor. Let's talk about things in the past that they can engage with us and won't get frustrated if they can't come up with the right answer of when was your daughter here to see you last. Also, looking at and identifying and treating those comorbid conditions. The rate of heart disease in individuals who also have dementia is almost 40%. People with dementia, a lot of times will live with kidney failure, chronic obstructive pulmonary disease, so many different kinds of medical conditions, comorbid conditions that they're dealing with. So if we can best manage that diabetes and keep those blood sugars and the blood pressure ranges where they need to be, if we can identify and address sleep issues, this is just going to lead to better management of the dementia itself. There are so many things that come as a result of high blood sugars. The person might get thirsty, they might want to eat all the time if their blood sugars are high, they might be more sleepy. And so a lot of times we might blame these new symptoms on the dementia itself when really they're due to the comorbid condition that person is dealing with. With activity planning, making sure the person's engaged in it, that they like the activity, that it's not too difficult. Providing those reminiscence activities. Again, looking at the person-centered care. What was this person interested in 30 years ago, 50 years ago? It might be something simple around the house that they want to be involved with. When I think about, my own grandmother, I don't remember her ever sitting down. She was always doing something around the house. So if that person is now in an environment where they don't have those activities to keep them busy, it's our job to really make sure that they are engaged and have those opportunities. Music has so many benefits, and a lot of times I think it's overlooked as an activity. We tend to have the TV on, but perhaps not providing music with that person. Simple crafts and hobbies, outings, and spirituality usually remain strong with individuals late into the disease, all the way through the course of the disease. So if this person had a lot of faith-based activities in their past, let's make sure that those are offered to the person. Might not be in the same way that they used to participate, but in a different format, and look for those opportunities. We've touched a little bit on good communication tips. We'll review these kind of quickly here. But another thing is that sometimes people with dementia don't understand the words that we've said to them. but they will always understand how we said it to them, how that message made them feel. So it's so important to watch our body language, our tone of voice, to remain as calm as possible. And I know you have this information, but a lot of times we need to pass this on to caregivers, that correcting individuals, arguing with them, trying to bring them into the here and now, those are not helpful interventions for people with dementia. We need to speak slowly and clearly, and practice the pause. Keep your sentences to about 7 words or less, but after you've said it, just put that pause in there. Give that person a little bit more time to hear what you've said, formulate their response, and then to respond to you. Really important to approach that person from the front. Take a couple extra steps, get right in front of the individual. If they can see your whole face, that's even more of a benefit. I know with masks, that's not always possible, but talking to the person, addressing them when you're behind them or to the side of them may startle them, and it might lead to an untoward behavior. Get down at eye level. If before you ask a question, ask yourself, can I put this into more of a statement form rather than a question? Use repetition if needed. Rephrase your question, rephrase your statement if it doesn't seem to resonate with the person. There are a ton of other communication tips that we can go through, and you probably have some of the favorites of your own, but we just want to leave you with these few tips here. Getting rid of as many negative words as possible, such as no or but, visual cueing, and avoid TMI. That too much information is really pertinent when you're conversing with a person who has dementia. Again, short, simple sentences, one idea at a time, no run-on sentences. And last, simplifying the environment. I think we've touched on this throughout the presentation. Again, cannot overstate the need for regular routines for individuals who live with dementia. And this obviously runs into consistent staffing. The better that care provider knows that individual and knows their routines, the more smoothly that interaction is going to go. Making sure that the lighting is appropriate. Are the blinds open? Are the lights on? Making sure we have as little distraction as possible when we're having those interactions. So much more that could be said about the environment and communication, but for time's sake, I'm going to turn it back over to Lindy, who's going to kind of wrap up the presentation along with Branka, who will be talking about care consultation, and we'll talk about some of those important community resources.
Awesome. Thanks, Marty. I'm just gonna kind of emphasize some of the things that we've already talked about, but just the importance of seeking out community resources, including education on dementia. We really are just scratching the surface of how to communicate with individuals, how to interact with them effectively. And there's so much more out there, and education that can be found to improve the quality of life for individuals living with dementia. With that being said, there are resources like the Benjamin Rose Institute on Aging Care Consultation, which I'm lucky enough to be able to deliver in the greater Toledo area. That is a great resource to help families, to connect them with services, but I'm sure there are other services in your area, such as the local area agencies on aging, that can be helpful as well to identify and connect caregivers to respite services. So look into those AAAs. And being aware of signs of burnout, depression, and abuse is also important, within caregivers as well as individuals living with dementia. So just looking out for those signs and how important respite services are. And just a reminder, if you're working as a professional or family caregiver, to connect with resources and refer to community resources as frequently and as often as you can, with kind of like a final note of encouragement that we really need to be supporting people to widen their support circle so they have a really team of people that are supporting them is the best advice that I can give to you all. And we'll go to the next slide. So this is one, and this is where the IDEA strategy comes from. So this is the Alzheimer's Los Angeles caregivers tip sheets, which is really great about these is they come in different languages. So they're different, one pagers, and the back could be in Spanish, or they have Japanese and other languages. So these are really great tip sheets that you all can learn more. Again, dive deeper into everything we've talked about today. Here are some of the topics. So these are live links. Once you get the PowerPoint, you can click on these and visit Alzheimer's Los Angeles's website as well. And we'll move on to talk about Ohio Council for Cognitive Health. So where Marty's from, they have a wide array of wonderful caregiver tip sheets. These are a little more in depth in the best way. Some of the topics include effective communication for people living with dementia. So these can be printed off at no cost or shared with electronically, really wonderful resources as well. And we'll move to the next slide. So this is one of my favorite books. So the next 3 slides are just a couple books that I wanted to highlight with you all that we thought were so important. We had to include them in this presentation. So this one is Coping with Behavior Change in Dementia, which is a family caregiver's guide. I use this as a professional. I've used this more than I can count on my hands. So this is by Beth Spencer and Lori White, a really wonderful book. Another book is the Alzheimer's Caregivers Playbook that was written by Coach Broyle, who cared for his wife who had dementia. A wonderful book in the perspective of a male caregiver. And we'll move to the next book, which is the Alzheimer's Action Plan, which is everything A through Z, everything you need to know about Alzheimer's disease. So just a couple of those resources. The next 3 slides, it's very difficult to see, but this is from the state of Minnesota Act on Alzheimer's. You'll be able to visit their website. They give very specific tools and toolkits of non-pharmacological strategies. They give examples of behaviors, those strategies. So those are the next 3 slides. I really encourage you to visit their website and look at some of these resources because they have absolutely wonderful work on their site. And I think that kind of wraps up Marty and I's presentation. I know we might have time for a couple of questions, but I'll give it back to you, Ashley and Branka.
Thank you, Lindy and Marty. That was a really great and such a thorough presentation. We really appreciated all the information that you were able to provide us. We do have a time for just a couple of questions from the audience. So if you do have questions, make sure that you are submitting them either using the Q&A or the chat feature. So the first question came in about respite services. They wanted to know if you had any suggestions for respite services support. They said hospice only offers 5 days outside of the home in a skilled nursing community. The short window of time in a new environment is very disruptive and traumatic. They're trying to find in-home respite support options. So they were wondering if you had any recommendations for options that are affordable.
I think I'll start, and then Marty, if you want to jump in. Just a reference again, I know in the greater Toledo area, we call our area agency on aging the Area Office on Aging of Northwest Ohio, but they have caregiver support programs. Depending on the area will depend how much funding, but they have at least in the greater Toledo area, caregiver support program that they can provide short-term facility respite as well as in-home facility or in-home some respite support hours. So really just encourage you to contact your local area agency on aging and see what is available for caregivers. You might be surprised. I'm hoping you're surprised of what might be available. Marty, do you have anything to add to that for respite services for caregivers?
I'll just add that, supplementing with in-home healthcare is sometimes helpful. And so there are a lot of different home care agencies you can look at. Some people look at hiring privately from a friend or a family member, but friends or acquaintances that they know that can provide that respite, just depending on the level of care that's needed.
Yeah.
Great. Thank you so much. I know that there were questions in the chat that we haven't had time to address. So I will pull those questions and we will email you individually with those responses. But before we conclude today's webinar, Project Director Branka Permetica is going to tell you briefly about BRI Care Consultation. So it's a care coaching program available for families impacted by dementia in various counties in Ohio through the Administration for Community Living Project. Branka?
Thank you, Ashley, and thank you so much, Lindy and Marty. We're getting some wonderful, numerous comments in the chat about how wonderful this was and how useful the information is. So thank you once again for doing this the third year in a row as a part of our ACL project. I'm going to tell you a little bit about an evidence-based program called BRI Care Consultation that's available throughout parts of the country. And for the purpose of this grant, we focus on certain parts of Ohio. So I will touch upon Ohio, then I'll touch upon other parts of the country as well. But this is a program that's a resource in several communities. It's a telephone and email-based care coaching program. And it really does support individuals with or at risk for developing dementia, including those with IDD and their family and friend caregivers. I will tell you, where the program lies and where the no cost is. If you just want to go to the next slide, Marty, I'm going to talk a little bit about the program, but how to access it. So basically, individuals and families are assigned to a care consultant, and they continue to build this ongoing relationship with one another. And a lot of the conversation takes place about finding and getting connected to health and community services. So things like respite that we just talked about. Also really identifying problem areas in a very flexible assessment process and prioritizing those concerns in a simple step-by-step action plan that really hones in on individual needs. A lot of the conversations that take place are around communication. So we learned a lot of really great tips. A lot of care consultants that deliver BRI Care Consultation have attended the behavioral interventions program, especially in Ohio. All of them have actually. Basic communicating with loved ones about managing difficult situations and behaviors. The care consultant stays in touch and makes adjustments as care situations may change. It also really focuses on assisting how to get other family and friends to be part of the care team, and as well as an emotional support for caregivers when overwhelmed or they face challenges. Marty, if you want to advance the slide. So as a part of our ACL project that's being led by the Benjamin Rose Institute on Aging, we have certain licensed sites that do deliver the program. So we have the BRI Care Consultation program, one delivered out of Benjamin Rose. It's called We Care Because You Do, and it's available in the 5-county area in Ohio. So if you call that number, 216-791-8000, you will get connected to the program. Welcome House is the program that serves individuals with IDD and their caregivers or supporters throughout the 5 counties, and you have the contact information there. Then also 2 rural areas in Southeast Ohio, Washington County, and they also serve parts of West Virginia and Woods and Pleasant, and then Athens County in Ohio. And if you want to advance the slide. We also know that there are many other participants on this webinar that are from all over the country. If you go on our website, a webpage under benrose.org, BRI Care Consultation, you will see all of the licensed organizations that deliver the program. And just, I want to let you know, Lindy is a care consultant. She's a wonderful care consultant delivering the program out of Memory Link Care Services that serves the greater Toledo area. You now know Lindy, you know how, she's a wealth of knowledge. So please contact her by, again, going on our website or just Googling Memory Link Care Services. And they do deliver this program in, again, the Northwest part of Ohio. So I'm going to go back to Ashley to wrap up the presentation.
Thank you. And we want to thank you again for joining us today for Behavioral Interventions when Caring for Someone with Dementia. A recording of today's session will be made available at www.benrose.org on the event registration page and in our resource library. You'll also receive a copy of today's presentation along with the PowerPoints in an email We will be offering more webinars like this for community organizations and families impacted by dementia. To stay up to date on upcoming webinars and all events that Benjamin Rose has to offer, such as Dementia Friendly Cleveland Heights Week that's occurring May 15th through 20th at the Lee Road branch of the Cleveland Heights University Heights Public Library, please visit our website, www.benrose.org. In the chat box, you will see a link to a post-session questionnaire. You will also be receiving it via email later today. We ask that you please complete the post-session questionnaire within 1 week following today's session. Your responses and feedback will be used to show the impact of programs like these and to improve the tools and resources provided to individuals living with dementia and the people who support them. Thank you again for joining us, and have a great rest of your day.